So my name is Jenna. I'm a respiratory therapist with Poplar Pulmonary, along with Tina. And as we mentioned, we have our guest speaker today, Susan Sue from BC Transplant. The Better Breathers Club of BC is brought to you through the BC Lung Foundation and hosted by Poplar Pulmonary Wellness. So thank you to BC Lung. We would like to acknowledge the lands on which we're on today. So where we work, live, and play. It's the unceded territory of the Coast Salish peoples. For Tina and I, and those of us in Vancouver, that's the Squamish, Tsleil-Waututh, and Musqueam nations. Feel free to let us know in the chat if you like the lands on which you're on today, where you're joining in from. We'd like to remind everyone this is a very safe space to share your thoughts and your values and opinions and ask questions without any fear of judgment. So we thank you in advance for creating this space for everyone. Information that we provide here is for educational purposes and does not substitute professional medical advice from your healthcare provider. And without further ado, I'll hand it over to Tina.
All right, so we have a bit of a two-part talk planned today. So I will kick it off. We'll just do a little brief history about lung transplant. We'll give an overview. And then I'll hand off to Susan, who is a respiratory therapist for BC Transplant. And she'll talk about, she's an organ donation specialist. So in order to get us going, I'd like to find out what you would like to find out. So usually with topics like this, you're looking to find, you've got some questions usually. So if you'd like to throw your questions out there, go for it. So if you have any questions, we will try to get them answered for you during this talk. You can put them in the chat or just go ahead and let us know if you have any questions or experiences you'd like to share before we get going.
I just have a question because it didn't say on the email I got. I don't think it said what the topic was. And I didn't know is the topic COPD, but now it sounds like the topic is lung transplant. So did I miss something or what?
Yeah, so the Better Breathers Club of BC is open to anybody with any chronic lung condition in British Columbia. And every month we meet and we have different topics and different presenters every month. So we try to present topics that are relevant to people with COPD, asthma, pulmonary fibrosis, and any lung condition really. So lung transplant was the topic for today's talk, but it doesn't mean that we can't field other questions. Did you have specific questions about COPD, Dory?
I mean, right now, my question is, how would I know that's the topic for today? Because in the email I received, it didn't say. Like, where does one find out what the topic is?
Oh, it was the email from the BC Lung Foundation, probably?
No, from you guys. It says Poplar.
And then, yeah.
Hi, I'm Tina, blah, blah, blah.
Yeah.
Yeah. So it
Time
just.
for the Better Breathers.
Yeah. Sorry, go on.
Yeah, we post the topics. They're on our website. So you can see ahead of time once we decide on the topic and guest speakers, we'll plug that in, as well as in the Poplar community.
I see. Okay.
Yeah. Yep.
I mean, personally, I have questions about COPD, but I know I could also contact one of you, I suppose.
Yeah, even if you wanted to reply to that email, that would be totally fine.
Okay.
Yep. Go ahead and reach out anytime. Anyway. Yeah, we're happy to help. Anyone else?
Well, I could say that I've had a lung transplant, and it's about 3 years ago now. So it's quite a process. Still on the wild ride.
Yeah. Thanks for sharing that, Ken. Yeah. So we are familiar with Ken, and I'm really glad that you were able to join us, Ken, because I think it's very important that people hear from those who have lived through this experience, because it is a wild ride, as you say. So feel free to pipe in with some comments anytime. We'll invite you to do that, to share your experience as we go through this. Yeah.
Thank you. Okay.
Yeah.
So I went a year ago down to Vancouver to talk to doctors about a lung transplant. So for right now, they're just kind of like, hold on to your lungs as long as you can, and just kind of keeping an eye on me. So I'm just here to kind of keep my information up and get more general information, because I know down the road it's going to be a thing I'm going to have to do. So the more information I get, the more knowledge I get about what could potentially be where my health is headed.
Yeah, great. Yeah, yeah, it can certainly be a scary thing to consider. So usually more information sort of brings down those fears and helps you have some knowledge to make the right decisions with. Yeah. Awesome. Thank you, Selena. Anyone else before I get started? Okay, so before we switch slides, I will let you know the perspective that I bring to this talk, and why I'm excited to talk about lung transplant. So I am not, disclaimer, I am not a lung transplant expert, but I am a respiratory therapist, and I have worked at Vancouver General Hospital, which is where the Lung Transplant Center for British Columbia is, for about 18 years now. And I see patients come through, whether they're waiting for transplant or being worked up for transplant. I see them in that immediate post-transplant time when they're in the intensive care unit. And then I see them maybe back out on the wards as they're going on their recovery. And then through Poplar Pulmonary Wellness, we see people living in the community, like yourself, Selena, who may be considering or being worked up for lung transplant, as well as people like Ken, who are living in the community after a lung transplant. So we've certainly had a lot of exposure to people going through this in our careers. Next slide. Can you switch this slide?
Sorry, just 1 second. There we go.
Yeah, yeah.
And there were just I'll just interject. Sorry, Tina. There were some questions in the chat that I believe you're going to address, you or Susan. So one is, I have COPD, about 50% lung usage. At one point, is transplant an option? And is it near end of life? And how long can we survive after? And then another comment, just Kelsey's here to gain a little bit more information to support her patients that have questions about lung transplant.
Awesome. Perfect. Okay, so for both of those, I think we will cover it. So we'll double check in with you towards the end to make sure that we have. All right, so a little brief history about lung transplant. So the first lung transplant that was done was a single lung transplant, and that was done in 1963. And sadly, that person only lived about 18 days, I think, and they died from renal failure after that. So the first attempts in the 60s to do lung transplants were not very successful. They could, do the transplant, but people didn't really get much life after that. So they stopped. But they didn't stop researching. They kept researching. New drugs came into play. Research went forward. And then in about the 1980s, lung transplants started coming back, and it became an actual treatment option at that point. And since then, it's only become more and more common and more successful. So in BC here, the Lung Transplant Center is at Vancouver General, and it started in 1989. And it's Dr. Yee is the thoracic surgeon that started up this program, and he's the driving force behind the program. So we do see him in the hospital. I know him to be a caring person. He connects with all of his patients before and after their surgeries. He gives talks to healthcare workers, to the teams that support lung transplant. So it does take a bunch of teams to to do this work. So it's not just people in the operating rooms, it's people caring for these patients before their surgery and after their surgery. And I know that Dr. Yi is quite appreciative and acknowledges how much of a team project it really is to support people through their journey in lung transplant. Next slide. All right, so this is the only graph I'm showing. Don't worry, there's not going to be a ton of graphs, but this is a good one. And we might even come back to it because it's actually got a lot of information in it. So this is Vancouver General Hospital statistics from 1989 up to 2020. So along the bottom axis, those are the years. So from 1989 all the way up to 2020. And then the numbers are on the left side of the graph there. And so when you're looking at the colors in this graph, this is telling also. So when they started, they were doing lung and heart transplants together. So you can see the purple. The purple is when they did heart transplants along with the lung transplants for some people. And then you see after 1996, there were no more heart transplants with the lungs. And so when somebody has lungs that are not working very well, it can put quite a bit of strain on the heart, the right side of the heart in particular. And so that's why they originally started doing a heart transplant along with the lungs. But they've learned over time that the heart can recover from the strain and the heart can regain function. So it's not necessary to transplant a heart just to start new. You can just fix the lungs and the heart will recover. So you'll see that we stopped doing the heart transplants along with the lungs a while back. The other thing you'll notice with the colors in this graph is there's a lighter blue and then there's the darker blue or turquoise color. And so the darker one is single lung transplants. And you'll notice that that tapers off. The last single lung transplant that we did at VGH was in 2017. And we don't do single lung transplants anymore. And so there is a reason for that. So research and developments show us that people who only receive one lung transplant don't do as well. So we always transplant 2 lungs. And I'll talk a little bit more about that in a bit, leaning into why that is. So this graph only goes up to 2020, but in 2021, they performed 66 double lung transplants. And in 2022, they performed 62. And I believe, maybe Susan, you might have some more current data, but we're still running in the 60s in terms of number of lung transplants per year, I believe. I don't think we've hit 70 yet. Yeah, and so it's good that we do a lot. So with experience comes expertise. And so success rates also go up in larger centers where they do more lung transplants. And so that's one of the reasons why you don't have a whole bunch of lung transplant centers in Canada with a fairly low population. So we keep the expertise by having only a few centers. So we have 4 lung transplant centers in Canada. They are in Vancouver, Edmonton, Toronto, and Montreal. Next slide. Transplanting lungs is not that easy. Lungs are difficult. They're difficult to transplant, difficult to live with someone else's lungs in your body. More challenging than with other organs. And some of the reason for that is that lungs are in contact with the outside world and they're in us. And so being in contact with the outside world means they have to provide some kind of immunity for us. So we don't want to just have organs out there susceptible to things. And so lungs do have all of these protective features, like our upper airways can do some filtering. We cough, so if we have if we happen to inhale big things, we can get them out. And our mucus, and we have little parts on our cells in our lungs that push things out of them. And so it's very important that all of that still keeps working. And I'll talk a little bit more about immunity coming up too. And the other thing that makes it quite a challenging operation is that the lungs basically have our full blood volume passing through them. So if we're going to take them out, we still need to keep people breathing and have the blood flowing while they do that. So it is a tricky surgery to do while keeping somebody stable. Next slide. So survival rates. So world survival rates it's about 6 to 7 years. So this data was 6.7 years. Within Canada, we're doing quite well as a country, 7.7 years. And in BC, 11.5 years survival after transplant. So yay BC. Reasons people don't survive or risks that are present with lung transplants. So there's some risk right in the immediate transplant time, which could be issues with the surgery, but it can also be issues with the new lungs. Lungs are delicate. They don't like to be moved around. They're susceptible to inflammation. So if the body has experienced any trauma or the lungs experience a trauma, the lungs might not work very well. If they do take sort of in that immediate, say, 30-day period, then the longer term complications are rejection. So they're calling this chronic lung allograft dysfunction. And basically the body is trying to fight off the lungs to protect itself. It knows it's a foreign thing. It's not your own tissue. And it doesn't work with the lungs that are there. One thing we do to help people accept the lungs, help the body accept the lungs, is called immunosuppression. And that's where we suppress the immune system. Usually we do that with steroids. So it's all medication-based that we try to reduce the person's immune system so that it doesn't fight off their lungs. But in doing that, the lungs become quite susceptible to infection. And if you remember, the lungs have to have some immunity themselves. And so that is also reduced. So you need to keep the lungs healthy while your immune system isn't working very well on purpose. And so it's very important to take all of these precautions like wearing masks, not exposing yourself to bugs. And then the other risk is malignancy, which is cancer. And I believe that is also related to the immunosuppression. So cancer cells are our own cells. And if our body's immune system isn't sort of getting rid of them regularly, we have a higher risk of getting cancer ourselves. Next slide. So who might need treatment with a lung transplant? So these are sort of the top 4 lung conditions that we do transplant for. So pulmonary fibrosis is at the top of that list. And that's because pulmonary fibrosis can be a very aggressive disease. And so people can deteriorate quite quickly. So it doesn't have a very good prognosis. So survival is only about 4 years after diagnosis as a median number. So lung transplant can provide a longer life for those people. COPD, on the other hand, can have different trajectories. It can be a slower trajectory, and it's not necessarily a beeline either, and it can be level off as well. So you need to look at the individual in that case with COPD and see how their specific lung condition, their lungs are doing over time. And then that can pose some challenges in trying to figure out when is that sweet spot? When is that best time to get a lung transplant? Maybe knowing that your lung function is deteriorating and sort of trying to predict how will your breathing be over the next few years compared to how would your breathing be if you get a lung transplant. And so we're looking at data, looking at the individual, and looking at their overall health status. Cystic fibrosis used to be way more common in terms of a condition to treat with lung transplant. Used to be very common. You used to see people with cystic fibrosis getting more than one lung transplant as well in their lives because they're diagnosed fairly young. But treatment for that has improved a lot. And so the need for a lung transplant in that population has gone down by quite a bit. And then the fourth condition is primary arterial pulmonary hypertension. Okay, next slide. Are we doing okay for questions so far? I'll just talk very briefly about the lung transplant procedure. Okay, this is my last slide. So the lung transplant procedure is so interesting. So this is a picture of lungs. I believe these are the donor lungs because they are both attached together and they're sealed at the airway and they're inflated. So these lungs are inflated, they're not collapsed. This is what they look like when they do have air in them. You can see the black spots. That's from life in cities. We're all breathing in some toxins. All of our lungs will probably show some damage over our lifetime. Our lung function does deteriorate as we age and as we're exposed to the air that we breathe and whatever is in the air that we breathe. So that would be kind of normal, but you do see a lot of pink areas here of good, healthy lung. And so when they do a lung transplant procedure, they do what's called a sequential single lung transplant. So we do both lungs, transplant both lungs, but do one at a time. So if you have two lungs, they might not be exactly the same as each other. So they'll take out the one that has the least blood flow or the most damaged. So the most damaged lung comes out first. During that time, when they take one lung out, your old lung, one lung, has to take all of the blood flow through it instead of two lungs kind of splitting the load of the blood flow. So it's a lot of blood flow. It's like double the amount of blood flow that has to go through that one not so great lung. So you are managed on that one lung. Then they put in the new lung. And so now we're back to two lungs taking the load. And then they'll remove the second old lung. And during that time, that brand new lung has got to support you. It's got to work right away. And then they'll put in the second new lung. So it can be very stressful on a body to go through this procedure. It is a big procedure. But there are things they can do to help if they need to. Some lung transplant centers will do these things as a matter of their normal course. Other transplant centers will only do this if they need to. So one of the things they can do is called ECMO, ECMO, which is extracorporeal membrane oxygenation. It's a mouthful, but it's basically a machine that can breathe for you. But in order for that to happen, the blood has to go out of your body through the machine and then back into the body. And it doesn't necessarily take that blood flow load off of the lungs. It just helps it to breathe in the meantime. And there are certainly risks with using that type of a machine. Yeah, so they don't, and at VGH, they generally do not do it unless they need to. But it is a fancy contraption that we can use if they're having trouble during the surgical time. That's my big overview. How about any questions? And welcome. We had some new people pop in the middle there. Hi, Paula. Hi, Jane. Hi, Andy.
Hello.
Hi. So we have Susan up next to talk, but if you had any questions for me before we get going, I'm open to that. Or we can have Susan talk for a little bit as well and then take some overall questions.
Just a thing for myself, I was wondering how many people saw that series on transplant that was on public TV. You saw it,
You got
Paula.
some hands up here. Yeah.
It was amazing footage, really, that brought you right into the operating theater while the stuff was going on and introduced you to the many players involved. And so it was really quite revealing and eye-opening. So if you have a chance, you can just go on PBS and they still have it on file. You can so you can watch it whenever you wish to, and it's still there. So just a word of note.
Thanks, Ken, for bringing that up. And maybe we can try and put the link in the chat actually to that.
Yeah, I'll look that up now.
Was that
Jenny. Knowledge
Network?
Knowledge
yeah.
Network, yeah.
Knowledge Network.
Okay.
And it's one of the transplant series. Yeah.
Okay.
Awesome. Thanks, Ken. All right. All right. Next up, we have Susan Sue, who is a respiratory therapist with BC Transplant. And she's the donation expert. So we've asked her here to talk about that. Susan, will turn the table over to you. Did you have a PowerPoint you wanted to share? Okay, let's, I'll just set the... Hold on. Did that go through?
Just while Susan's bringing up her presentation, I just wanted to add to Mitchell's comment. So he was just asking about when is transplant an option? Is it near end of life? And the answer is yes. You do have to be in end stage lung disease in order to be eligible for a transplant. However, you can get referred to the transplant program maybe a little earlier than that. So you just work with your physician, like Tina was saying, to figure out the timing.
Yeah, it is a little bit of a sweet spot. So you want to be healthy enough to go through the transplant process and do the recovery. So a lot of that has to do with being physically fit. And so some people will have to go through pulmonary rehabilitation either before or after transplant. So if you do feel like you may need a transplant, staying fit and healthy is the best thing you can do for yourself and will help you have better outcomes as well. Yeah, so you don't want to be so far along that you're, bedridden. You've got to still be active. So it's not like right at the end, that's too late. Yeah.
Can you guys hear me okay?
Yeah.
And can you see the presentation okay?
Yeah.
Okay. Hi, everybody. Thanks for having me, Tina and Jenna. So like Tina said, I'm a respiratory therapist by training. I've been a respiratory therapist for almost 20 years. And I started working with BC Transplant about 3 years ago as a donation coordinator. And I'm also now the in-hospital coordinator for all of Vancouver Coastal. So I oversee all the donation cases in Vancouver Coastal, and I help with policy development and education. So today, Tina and Jenna asked me to bring some information about organ donation. So I'm going to do a quick overview of organ donation. And then if you have any questions at the end, please let me know. Or if anything comes up, you can just stop me and I'll explain it, okay? So BC Transplant is the organization that oversees all aspects of donation and transplantation across BC. Our goal is to increase organ donation, reduce the number of patients waiting on the transplant list, and also improve the care we deliver to our recipients and our donors, as well as their families. We also oversee the organ donor registry. So the BC Organ Donor Registry is BC actually has the very first organ donor registry in Canada. People can go online to register or do a paper form, and people could, so everyone could register. There's no age limit in registering. And you can register your wish as either yes, you want to become an organ donor or no. And then if you do wish to become an organ donor, there's also options for you to select what organs you would like to be evaluated. So if you're not an organ donor yet and you're interested, all you have to do is just go on our BC Transplant website. It takes 2 minutes to register, and it's really quick. All we need is your PHN number. And once you registered, it'll come into our profile. And in BC, so Tina asked me about opt-in and opt-out. So in BC, we actually have an opt-in program for donation. For Canada, most of our provinces are opt-in. However, Nova Scotia is one of the very first provinces across Canada that does opt-out, meaning if you don't register your wish, you're automatically considered as an organ donor. There's our pros and cons. So the opt-out would be you have more option, like more numbers of donors across your province. However, that being said, all organ donation programs, we heavily rely on family, because without family, we won't have donors. And if your family is not wishing to proceed, we will honor that wish. So it's very important that when you do register your wish to become an organ donor, it's important that you have that conversation with your family so that they're aware that this is one of your final wishes if you come to that end of life. So in BC, there are 4 different ways to donate. We do have a living donor program, which helps with kidney and liver donation. And then we also work in conjunction with Eye Bank of BC to help with eye donation. So eyes include the cornea of the eye and also the sclera. One thing that I learned recently that's really interesting is that, did you know, 1 eye donor can help up to 10 people in need, 8 for sclera, and then 2 for corneas. So eye donation is quite powerful on its own. The two different donations that I predominantly see are the ones in the hospital that are in the ICU. So we have 2 different pathways. One is that someone could donate after they have been pronounced brain dead. And then the other pathway is we will donate after someone has been pronounced that they've passed circulatory disease. The 2 different pathway, the difference is that for the brain death pathway, we can consider the heart for donation. Whereas the other pathway, the heart cannot be considered, but we can still consider the lung, liver, pancreas, whole pancreas or islet cells from the pancreas, kidneys. And also the second pathway, this DCC pathway, also open up the option of donating after someone is going through, after someone who's going through medical assisted dying. So this is our donor stats that was released in the beginning of this year. This is our 2024 donation stats. In 2024, our numbers are a little bit lower, but still we made some record-breaking numbers. So we did a total of 481 life-saving transplants in 2024. We have 118 deceased donors and 90 living donors. The previous years, we only had probably in the 70s for living donors. So even though deceased numbers are down, our living donor program actually has gone up. And if you look at the lower bottom green box, the number of transplant referral we got last year also went over 1,000. And previous years, it was just under 1,000. So even though it was a slower year for deceased donation, it was a really busy year for us still because of the sheer amount of referral that we got last year. So despite our success in donation, people are still dying on the wait list. So as of if you look at the very bottom graph, in 2024, at the end of 2024, we had 666 people actually waiting on the transplant list. And unfortunately, last year, 13 people actually died while waiting for a life-saving organ. So a little bit further breakdown about the stats. So like I said, so this graph shows us the number of referrals that we've gotten throughout every single hospital in BC. So if you look, we started in the 400s in 2016, and within under 10 years, we've gone over 1,000 referrals. This is organ donors in BC by type. So for deceased donation, like I said, in 2024, our number is a little bit lower. We only had 108 deceased donors. The previous 3 years was actually quite busy. We had over 150 deceased donors. And living donor, like I said, last year we broke some records. We had 90 of them. This bottom graph is deceased donor in BC by health authority. So Fraser Health obviously is our biggest health authority, so they traditionally have the most donor numbers. But in every health authority has been working very hard in the last couple of years to bring awareness about donation, and we're continuing to work hard to bring awareness to the public as well about organ donation. And lastly, I just wanted to highlight the number of transplant by organ that we did in the last couple of years. So Tina, you were asking about what was the most amount of lung transplant we did. 2023, we actually hit 77. So we did 77 lung transplants in 2023. It was a very, very busy year. Last year, like I said, the numbers went down a little bit, but just looking at this year's trajectory, I think we're getting close to where we were 2 years ago. Yeah, so in 2023, Dr. Yi had a really busy year. So a lot of people are wondering how long transplants would prolong their life. So patient survival versus graft survival. So patient survival meaning how long a patient could survive after they got the transplant. Graft survival meaning how long the organ that's transplanted will last. And if you look, these numbers are actually quite similar. And these are stats that were collected from 2000 to 2020. So this is for kidneys. And then we have liver, heart, and lungs. And if you look at lungs, the numbers are pretty comparable. So 1 year survival rate is 91.6%, and same for graft. 3 years, 81, 5 years, 76, 10 years, 65. So these numbers are all going to vary. These are just average number that we've obtained. And honestly, it depends on how well you're taking care of your new lungs. It definitely plays into big effect about the longevity of your graft. I actually have a couple of volunteers that work for BC Transplant that have had their lungs for 25 years. So it could last for a very long time for some people. Any questions so far before we move on to the next topic? Okay, so I'm just going to quickly review the donation process so that everybody knows what's involved. It all starts with a referral and donor screening. When we get a referral from the hospital, we'll typically go into a very deep dive about the patient to make sure that our donors are safe to move forward with organ donation. And that includes looking through every single document this patient has in their medical history through Care Connect. So for us to ensure safety of our donors, we actually go through every single medical encounter they've had, every single lab, and every single imaging to ensure that we don't miss anything. And once we know that these patients are eligible to move forward as an organ donor, that's when we'll make plans with the family and do what we call a consent and medical social process. So since COVID, we know that everything can be done over the phone. So family meetings now can happen over the phone or in person. And during the family meeting, usually we spend the first 10-15 minutes going over what donation would look like and explaining the process. We always offer organ donation as an option at the end of life, just so that family knows that when they speak to us, they're not obligated to go through with the process. And then if the family do want to move forward, that's when we'll do a consent and also a medical social questionnaire to learn more about our patients. Now, once my part is done, my counterpart in the ICU will start the organ donation workup. And what that includes is a lot of blood work. We'll do testing for the heart, if the heart's being considered, testing for the lungs, as well as testing for any abdominal organs. And these tests include CT scans, X-rays, bronchoscopy, or like even biopsies sometimes. Once we know that the organs are safe to donate through our testing, that's where we'll start looking for recipients, what we call organ allocation. And to allocate organs, we first go by blood type. And then once we know the patient's blood type, organ allocation actually matching organs is very important regarding the size, because I'm a very short person, I'm 5'2". We will not give someone my size, someone who's 6 foot organs, because their lungs would be way too big for me. So sizing is very important. And then we go by medical urgency. So if you're really sick in the hospital and you will die shortly if you don't get a life-saving transplant, we actually have an organ sharing program across Canada to help the sickest patient. Now, there are two types of medical urgencies. One is that they're high status, meaning they're really sick in the hospital. Two is that they're highly sensitized, meaning they're very difficult to match because of the body's antibodies built up. Once we go through the high status and the highly sensitized, that's when we'll try to allocate within BC because of logistics of transporting the organs, because once the organs are flush with what we call the co-caloric, they're only good for a certain amount of time, because so they need to be implanted almost right away to ensure graft safety. However, if we can't find anyone within BC, we will extend our search across Canada and also the US in hopes of extending that gift that someone is able to give to other people. So once we have recipients lined up, that's where we'll go into the OR for recovering the organs. For BC Transplant, we have a mobile team. We actually will fly our team to different hospitals in BC to retrieve organs and bring them back to Vancouver. So if you look at the middle picture, we bring a lot of equipment with us when we go out for retrieval. And as you can see also on the transplant show, that our team will go out for recovery. For specifically for lung transplant, so lungs, once we get the organ out, we have to re-implant them within 4 to 6 hours. However, that being said, in BC, we have a machine called the Ex Vivo. What it is, it's actually a machine that could help breathe for the lungs, and also we can clean up the lungs before we implant the lungs. We could inject antibiotics to make sure that the lungs are better conditioned before we implant them. We have used this machine several times. Some programs across Canada definitely use this machine religiously, but it's all depending on physicians' preference. We have used it a few times, but like I said, other programs do use it religiously. And you can see Dr. Yi trying it out on a set of lungs in this picture. There are 3 different transplant hospitals in BC. At BC Children's Hospital, we have a pediatric heart program that's kind of on hold right now. So our sick kids are going to Edmonton for their heart transplants, but we do have an active kidney program. All the lung transplant are done in Vancouver General. VGH also does liver, kidney, pancreas, and islets from the pancreas. And then the St. Paul's, they have the heart program and also a kidney program. And then in terms of family care, we are available for family 24/7. We also offer mementos for the family when they go through organ donation, such as the pewter heart that you see in the picture, which is a bigger heart with a smaller heart inside, basically a memento that connects the donor and their family during the organ donation process. The ICU also has programs where they will cut snippets of the donor's hair and also print strips of their heart tracing so that they could keep it as a keepsake. We also honor anyone who has any religious background. We do smudging ceremony. We do Buddhist chants or prayers before the patient goes into the operating room. And I don't know if you guys heard of an honor walk. Sometimes we'll have family or healthcare workers lined up the hallways when we take our donor into the operating room. And every year we actually have a ceremony that honors our donor family. So we bring them back and they will say a few words about their loved one, and they're presented with a medal for thanking the gift that they're giving others in need. So we have a social worker in our program who also will connect with donor family and recipient families so that they could meet if they choose to. So that's pretty much all I have set up as a presentation about organ donation. Do you have any questions for me right now?
Thanks, Susan. That was fabulous. Thank you.
So, Susan, one of the things I'd like to note is that my donor was actually a street person who died of an overdose, and there's really quite a number of the donations that were made that came from persons who were street involved. I was under the understanding that it was somewhere around 30 to 40% of the donors came from that source.
Yes.
Is that right?
Yeah. So being a drug user doesn't exclude you from becoming an organ donor. We actually do very rigorous testing when that comes up. We actually do serology to check for any communicable diseases. We're very diligent with our care for our donors because we know that we also will disclose what kind of disease is tested positive so that you have an informed decision that whether you choose to take these or this particular organ or not. That being said, actually hepatitis C organs are transplantable now because there are treatments for that. But like I said, once we do the donor testing and we know that there's any positive or anything that comes up on their serology, the transplant program will know right away, and the transplant program will present that to you when they offer you the organ. So everything's quite transparent, and this is bound by Health Canada.
Yeah. Yes, well, and totally the case. I mean, for myself too, I needed to sign a document of acceptance for the organs with the full knowledge of or understanding of the background of the individual.
Yes,
that they're in a high risk position.
Yes, yeah. Any type of risk we'll disclose, so that you can have that informed decision, because in the end, you can choose whether to accept the organ or wait until the next one.
Yes, well, I really hadn't seen that mentioned in in a lot of literature. So one Christmas, just before Christmas, I wrote a letter to the Times columnist, describing my experience with this. That how much I really appreciated, and how many others really appreciated the fact that the families were able to make this contribution that kept us alive.
Yeah, it's quite powerful. It's definitely very eye-opening since I started working with organ donation, because before, as a bedside RT, I feel like my scope is a bit narrower because I only see what happens in the ICU. But when I got into this position, I had no idea that one transplant case take up to 100 different professionals involved, right? Because it's the pre-transplant program, the post-transplant program, the donation program, ICU, OR, imaging, lab, right? There's a lot of people involved in this process.
Oh yes, yeah, it's quite phenomenal.
Yeah.
Susan, do you mind stop the screen share just so we can
for sure.
people a little bit? Jenna had a hand up too, and
we
have some questions
so we've
in
got
the chat.
Some questions in the chat. You've got it. So our first question is, how long is recovery time?
Okay.
Nice.
Typically so we divide the body into two parts. So we call above organs, meaning the heart and the lungs, and then below organs, anything in the abdomen. So your liver and kidneys and pancreas. Usually for a full case, if we are recovering all the organs, it's about 3 hours for recovery. And then the implanting, I think lung transplant typically takes between 4 to 8 hours, but usually around 6 hours from beginning to finish.
Oh, the
surgical
time.
Yeah, surgical time.
I think we were asking about the recovery time. So for receiving new lungs, you would first go to the intensive care unit. And I think the average time there is about 4 to 5 days. And then going up to a hospital ward where the average time is just about under a month. And then there's a home period of recovery time where you have to keep coming back to the hospital regularly. So staying within the vicinity of Vancouver General for another 3 months. And then the visits get less and less frequent, so people could move a little further away from the transplant center. But there is still follow-up, I believe, up until about 6 months. Ken, what was your experience?
Well, actually, interesting enough, I was discharged within 12 days of the operation.
Amazing.
And mind you, I could barely walk, but there was, yes, and then I spent a further 3 months in Vancouver, or 3 months from the date of the operation. And I spent now, and I've been in touch with many people sort of across the province, and the experience is so it's so different for each individual. So I don't think that there's any. I mean, one can talk in generalities, but you know, it's in my
Doesn't mean that'll be
experience, yeah,
yeah.
it's like there are so many variations to what happens that it's really important not to base or have the expectations that your experience is going to be somebody else's. It just won't be that.
Very good point.
But certainly, the most important part of all this is maintaining conditioning prior to. I've got to say that you know, right up into you know, just really like 10 days before I I went into hospital. You know, I was working out 3 times a week for at least an hour a day, and I could barely walk, but you know, I really did maintain some form of exercise using weights and bands and following online direct exercise programs over that period of time. And you know, I've got to say it's so important, you know, looking after what you've got prior to, you know, so that you're in good health when you go in.
Thank
That's
you.
right.
We have a
New lungs,
question.
but same body.
Yeah.
That's the thing. Yeah, sorry, I think Tina, you're going to jump to the chat. So Ken's comments kind of leads into Kelsey's question a little bit about what kinds of reasons could a recipient be denied? And maybe I might clarify and ask, you know, there are different parts to the transplant wait list. There are 2 lists, is my understanding. So there's that kind of pre-transplant assessment, and then when you're on the active list. And so maybe Tina or Susan, if you could speak to both. So like criteria, or what would be criteria for people to be denied a transplant? And does that ever happen in the active list?
Yeah, you can be on the list and taken off the list. Yeah.
It depends on if you have an active infection, because if you have an active infection, automatically they'll take you off because they wanted to make sure that it doesn't affect your graft function afterwards. So they'll make sure that the patients clear an infection before they're moving forward. Even while on the active list, there are different categories that they will file the patients in depending on how sick you are. There are 3 different statuses. If you are status 3, that means you're the sickest one, and they will consider you with every offer that we have for organs, if that's your match. And then if they're status 2, meaning they are sick, so they'll entertain every offer, but they won't accept like every single offer. They'll only listen to the ones that are a better match that patient. And if you're status 0, that means you're well enough in the community that you don't need to be transplanted right away. So it all depends on which category you fit into. That's how long it's going to take for you to get an offer. Another reason that you might be denied of a transplant is maybe during your workup, something came up that's suspicious of cancer. Anyone who's been diagnosed with cancer, you have to have a 2 to 3 year remission before you're even considered, from what I understand. I work with the transplant program, but I'm not part of the pre-transplant program, so I can't say for sure, but that's something that's come up before from my experience.
Yeah, and it's one of the sort of longer term risks of having lungs because of the immunosuppression is cancer. So if you've had cancer close to when you would get a lung transplant, the chances would be higher. There are a lot of criteria for lung transplants, and I don't know them. And the criteria is something that they look at regularly. So there are relative contraindications. So it's not always like, yes, no. They look at all parts of the whole person and put the image together of how healthy is this person, how likely is this transplant going to go, and look at the whole thing. So maybe one person got denied because they had a certain thing, somebody else had a certain thing, and they got accepted, but there were other factors in play. So I have not really seen like a solid list of for sure yes, for sure no, because it doesn't always play out that way. And certainly conditions change too. So as survivability goes up, and availability of donors. So, maybe we have an older donor, which we might not want to put into a younger person, but if there's an older person who might be coming off the list soon, maybe we'll put that through. So, yeah, relative contraindications, I think, is the way to think about that. Yeah.
That might be the topic of our next talk on this, perhaps. Which leads us into Paula's question. So you are working with the pre-transplant team. So how long after your final pre-transplant assessment meeting do you find out whether, she says whether it's yes or no. Do you mean, Paula, whether
To be
you're on
on
the
the list.
active list or not? Yeah, okay.
After your final pre-assessment meeting, so after all of the testing is done, Paula, is that what you're thinking?
Yeah, they've given me a final date of May
Okay.
26th to meet with the transplant doctor, the pharmacists, and somebody else. I don't know. It's a whole day. And they said, because I'll have had everything done. Like all that page of testing. I have one more to do in Vancouver. And then they're the ones that sent me the thing and said, okay, you come to Vancouver and we'll meet you. And then it's like, okay, so how long after this meeting, or is it that day, or?
Yeah, that's a good question, and I don't know the answer to that. I know that if they do have questions that come up, they're gonna keep looking into things. And I don't know if that appointment is they're saying, like, we have an answer, we're just gonna wait till that meeting to tell you, or if this is where they're discussing any concerns or whatnot. So I am not sure. Susan, do you have a input on that one?
I'm not sure because, like I said, I don't work for the pre-transplant program. I know that every 2 weeks or even every week they host rounds. So that's where all the respirologists and the transplant docs will talk about the patients that are being tested on and what testing needs to be done. So, like, if you've seen that transplant show, they actually showed a section of that discussion that they had about one of the patients. So those rounds happen frequently and regularly. So I think it depends on when they get a chance to talk about your case. So if all your testing's done, likelihood is you'll be presented at the next round. So I'm not sure about the timing, unfortunately.
I know that for myself, Paula, after I met the doctor, it was pretty quick. They still had the test that you're probably going to be sent off for, which is they're looking maybe at your swallowing or something. That's just a guess on my part. It's something that I seem to recall was my final test, and fairly unpleasant one, but necessary all the same. And they were waiting for the result of that to come back. And they waited only about 2 or 3 weeks in my particular case before they said, yeah, we're going to put you on the wait list. So it may vary from that if there are other complications that in that sort of final assessment. But it's usually, as I understand it, from speaking with other people, it does tend to happen fairly soon after, like within a month or so, right? And I think I can feel kind of safe with saying that, but it does depend. If there's complications, they'll discuss what those complications are. They will maintain good communication with you so that what the status is sort of going forward. And yeah, so that's sort of the best I can come up with.
Okay, thank you.
Thanks so much, Ken. So it's just 5 after the hour. There's just one last question in the chat box, but Susan, we realize if you might have to go. So you're welcome to stay for this last question if you can. And it's what happens if the body rejects the lungs, which is a really big question. But do either of you have a comment for that one?
So the first line is that they will try different immunosuppressant therapy to see if it will help with the rejection. Patients are prophylactically put on anti-rejection meds after they get their transplant, but there are different types that they could try to see if they could stop that process. I have seen patient get a second set of lungs because of rejection before. Rejection happens at different pace for different people. It depends on how your body reacts to a new graft. So it's really hard to say, but usually the first line of defense that they do is they will try using different drugs to suppress the process in the body. If that doesn't work, they might relist you as a second transplant recipient, like a second try at the lung transplant surgery. But that, like I said, that depends on the severity of the rejection, and it also depends on like your how well your body is doing after the surgery, and whether your body is strong enough to go through another another transplant process.
The other thing that I think you know, in talking with other people who are post transplant, over the course, especially in the first 3 years, there's a fairly high incidence of is it CLAD? Is that what the term is? That occurs. It's a fairly common thing, and in all the cases I've heard of which there are about 4 or 5, it was easily treated with just an increase of prednisone. They just move your prednisone in to reduce the inflammation, and then they bring it down gradually over a period of time. So you know, that's what in talking to people who have gone through that is what has happened with them. So
thanks for that, Ken. Yep, awesome.
All right.
I do have to go soon,
Yep,
but I
we'll-
just
Thank
wanted
you.
to thank you guys for having me. I think you guys might have seen the most recent news about this poor transplant recipient waiting for lungs, and unfortunately, he was pulled out last minute. I just want to speak a little bit about it because there's a bit of a misconception about what had happened. So unfortunately for this gentleman, he did not receive his lung transplant the day that he was scheduled because of reasons that the hospital was short-staffed. But on the initial news report, it said that the lungs were discarded, which is totally untrue. So from BC Transplant's perspective, we will not retrieve any organs that don't have a recipient in the end waiting. So for this instance, I was actually working on the case. The lungs were actually left in the donor's body. We never retrieved it. But it was a shame because working on this case, I know that these would have been good lungs. And it's unfortunate that that happened. But I think the hospitals are all looking into how to make sure that doesn't happen again. Unfortunately, it was a very sad day because there were patients that were really sick coming into VGH and MERGE that needed emergency surgery, and there was just not enough perfusionists around to help support the case. So perfusionists are the people that put patients on the bypass machines while they get their surgery. And unfortunately, the patient that came through in MERGE also needed the help of a perfusionist for their surgery. So that's why. But yeah, if you have any questions at all for me, you can either let Tina or Jenna know. They could share my email with you. You can email me directly. I am happy to answer any other questions you might have later on.
Thank you so
Thank
much,
you so
Susan,
much.
and thank you for telling us that, giving us that clarification as well, shedding light on that. I want to thank everybody for your participation here, your honesty, curiosity, and for sharing your experiences with others as well. I think it's very helpful for people to see what goes on with this stuff. And you know, Ken, you couldn't have said it better. Each person's journey is unique, and that's the bottom line. But it's still good to find out what happens. And dispel some of those mysteries and find resources to have some of your questions answered. So thank you so much, everybody, for participating in this Better Breathers Club of BC on behalf of the BC Lung Foundation and Poplar Pulmonary Wellness. Thank you so much. We hope to see you again next month.
okay.
Thank you.
Thank you both.
Thanks, everyone.
Thank
Thanks for the
you.
info.
Okay.